Welcome, guys, to JPS Health and Fitness Podcast, and we have a very special guest today, Dr. Quinn Hennoch. Welcome, Quinn.
Thanks, I appreciate it. Honored to be on.
And Quinn is one of the most highly regarded physical therapists in the barbell community. He's got his doctorate of physical therapy from the University of Indianapolis, and he's the head of Rehab for Juggernaut HQ. And in my opinion, as well as most of the lifting community, he's internationally recognized for his skills in physiotherapy, as well as his ability to get athletes back in the gym lifting pain-free. So I'm very excited to have Quinn on today and help bridge the gap between rehab and what we do in the gym. And I couldn't wait to get him on the podcast. So thanks very much for your time today, Quinn.
Yeah, Jacob, thank you. I appreciate the intro. I'm not sure if half of that is true. I definitely am at Juggernaut HQ. All the other accolades, I'm not sure of. Still trying to learn in this thing, but I definitely appreciate it, and I'm looking forward to tackling some tough questions.
Awesome. And one of the first things I wanted to talk to you about today, Quinn, is what makes a good healthcare practitioner, because there are a multitude of different methodologies, disciplines, qualifications that exist in the field of rehab. So why did you choose physiotherapy instead of some of the other disciplines? And what are the qualities you believe to be critical in making a good practitioner?
Yeah, I picked physical therapy not because I thought necessarily that it was better than anything else. I honestly wasn't aware of a lot of other professions out there. I didn't really know what osteopathy was. I didn't know, I had experience with chiropractors, but what I wanted as a strength and conditioning coach was the bridge of knowledge for injury rehab. Knowing now what I know about professions, I could do that. I could do the way that I practice now. I could be any title. It doesn't. The title is just that. It really doesn't matter. A physical therapist and a chiropractor and an osteopath can do the same things. It just their schooling may be a little bit different, geared towards certain biases, but it's all within similar scopes. Now, osteopaths are actually considered medical doctors, at least in many circles. So they actually have far more reaching scope than I do as a physical therapist. I don't write prescriptions. I don't give any types of injections. I don't order imaging. I really. Yeah. The diagnoses that we make are very general, tendinopathy, rotator cuff impingement, all these kind of garbage terms. We're more of just, I always say that myself as like a glorified strength coach, because I really just end up finding the loading strategy that I can get this person back, and get them conditioned again to their goals, whatever that may be. But so I chose, as a more naive person when I was, 21 or 22, I chose physical therapy because I thought I imagined that I was going to be, 3 years in the Nike rehab center, and I was going to be, LeBron James's physical therapist, his student. That's not the case, as a lot of us know, have gone through the programs. You're trained to be a generalist, but I chose physical therapy for more of the movement bias as to what I thought. Now, to your second question, like what makes a good practitioner, there's no book or there's no golden rule, and so I think I'll kind of I'll spin the question in regards to what I do and kind of what guides me. And that's by no means saying that I'm a good practitioner, but I will explain kind of what I do, what I don't do, and the reasons behind it. I think the quality of continuously seeking information from reputable sources is a good quality to have. I think those sources should be, for the most part, peer reviewed, scientifically referenced resources. I think PubMed has been my best friend the last few years, and what I've gotten away from a self-education standpoint is the reading of blogs. I try to sift through the internet as quickly as I can, which is funny because I've based most of my career on social media, but the information gleaned, I try to make it from peer-reviewed sources, and I take that and I try to drive it into practice. And I think that there's always an argument, evidence-based practitioner or evidence-informed practitioners maybe is now like the mainstream term or more politically correct or whatever.
Yeah.
And then the argument is always, well, the clinical practice is always 10 years behind the research and all these things. And, we have to be progressive. But, I'm not sure. I'm not sure the logic behind an argument such as that holds. It would be like I choose an intervention because it worked for one person or because the guru said it works, right? The guy who's got a lot of followers says he does this, and so I'll do it too. If we did that in the medical community, so like actual medical doctors, I'm a doctor of physical therapy, but it's like, fake doctorate. Can't do anything. You know what I mean? It's like real doctors. If somebody were to prescribe a medication, it's like, hey, Bob, take this. It worked for Joe. We don't really know what it does, but it worked for a couple guys down the street. So just take it. We'll see what happens. It would just, that's laughable. That would be malpractice and people could die. And so I think because in the rehab community, in these allied health professions, such as physical therapy, it's not usually a life or death situation. Yeah. We can experiment with these like new gadgets and all these things. I think that it becomes a little bit more complacent. But, I don't think if we are to be taken seriously in the healthcare field and to have the perception from the public that we want, I think that we need to be a bit more stringent with the interventions that we choose. And that's in, evidence-informed practice. And so I think a quote unquote good practitioner or a nice quality to have is using the evidence to inform your practice and also to tell you what not to do or to hold off on until we get a little bit more information. If 10 years, if we were behind the research by 10 years, that's kind of what they said about kinesio tape 10 years ago. A colleague of mine in PT school who's got a few years on me, he said that when he was in physical therapy school, they were just introducing kinesiology tape and that just whole idea. And in school, they were taught that the blue tape had a cooling effect and the pink tape had a heating effect, right, with obviously no evidence to back that up. And so thank goodness that we have research to just debunk that kind of nonsense. And so it's like when you really look at it, like logically, it's actually flip-flopped. We should use the evidence to, if something is not substantiated, then maybe you'll hold off on it. Just think of the medication. Like I'm not going to prescribe you these meds until I know exactly what they do, or I can at least explain to you the mechanism. And so that's kind of what drives me currently.
I think that's a brilliant way to practice in any profession, whether you're in the allied health or you're a strength coach, being evidence-based and having an understanding of what the science is saying in terms of guiding practice and then basing that on your own experience within the client's needs. I think it's a fantastic model, and all practitioners should look to that to some degree. And you've mentioned in the past that physical therapy is just a license, and as a result, there's no standard operation of procedure or science, as each school teaches a different bias and so forth. So you mentioned the kinesio tape. So what are some other signs that a physical therapist isn't evidence-based and are engaging in voodoo pseudoscience practices?
Yeah, so this is where I anger half the world, or you lose half your listeners or something like that. I think I'll try to. Because when I talk about specific modalities, anybody who then uses that modality tends to take it as a personal attack. And this is just not when I talk. Like, who am I? But when a specific modality is discussed in kind of a skeptical manner, or questioned in a healthy manner, I mean that's what drives our profession forward. Then sometimes the individuals who use said modality will take that as a personal attack. And so what I'm going to try to spin, maybe talk about what I do, the things that I don't do, and why, and just hopefully spin it in a way that just makes us all think and that we can discuss in a healthy way. Really, my interventions are very, very simple. And when you would look at it in a cash-based model, the way I am, I don't mess with insurance companies. It would be like very difficult to make a living because I take a minimum effective dose
approach
perspective. And I think that's what, I think that's what healthcare should be, right? We should only be involved if we need to be. I don't want to see you in my door. Now, from a business standpoint, that's very, very stupid.
That's bad business.
What I should say is that my hands, these healing hands, you need these 3 times a week for the next 6 months, And in fact, if you buy a package, then it'll get you a little cheaper. So let's just sign you up right now. That's what it should. But I think if somebody took a bird's eye view of my practice, they would say, wow, he's just a coach who happens to, sometimes assess things with his hands. He looks like he moves joints around, but he, people are just working out. And that's really what I do. I have a very niche population that I work with. I'm in a very unique situation. My clinic is attached to, like, as you mentioned earlier, Juggernaut Training Systems, which is a pretty specialized niche of a group of people. It's barbell athletes, it's weightlifters, powerlifters, CrossFitters, it's the American football guys that come in. It's we get throwers, basketball. I mean, we strength and conditioning, but it's everybody is an athlete. Even we get general public, but they're still very, very active. I can literally think of 2 people in the last 2.5 years who were family members of one of the athletes that we were seeing, who came in my door and who's like not really into working out. We just needed to work on some stuff for daily life. And so I'm in a very niche population. And so I think that's what biases my way a little bit. But my perspective or my go-tos are education, for one. Let's talk about why you are in the situation that you're in, and usually that corresponds with some programming errors. And so it's very important that I understand programming variables and like strength and conditioning programming, and because that's usually what the problem is. It's like, you tried, your knee started hurting 3 months ago, and that's about the time that you started doing small off strong lifts and your 6-day-a-week weightlifting program all in one. You know what I mean? It's like, there's nothing I can do for you, bud. We gotta just make that modification. You overdose, obviously. And so that's number one, is putting things in perspective. And that's not very sexy, but it's extremely important. The education, the setting expectations is extremely important. From there, we've got to look at acute versus chronic issue. And so if it's something that's been going on for a long time and there's not an active inflammatory state, we're probably going to be pushing things a little bit in regards to, let's find what we can train. This is probably something that's in your head more so now. You've been thinking about it. It's been a year, it's been 2 years, or it's been several months, and you've missed a couple meets, and you're healed, but there's still some of that sensitivity, both mentally and just kind of that chronic sensitization. So, but we're looking for loading strategies that we can impart right away. And it's really the same with an acute phase. It's, let's let Mother Nature do her thing. And, let's see what we can train in the meantime. And so it's very much so exercise modification and trying to find ways to get a training stimulus without exacerbating the exact issue that came in for. And that's essentially what I do. I don't, if you name a modality or an entity or like a school of thought, I probably don't do it. There's dry needling is not even allowed in my state. So that's out regardless. I don't have to worry about that. I don't do cupping. I don't use the instrument-assisted soft tissue. I've done all. I have experience with all of these things.
Yes.
I do very little. I choose not to do a ton of manual therapy because the goal for me is to shift the locus of control to the athlete. I don't want to create dependency. Yeah. And I much more so enjoy coaching people through and getting them out of there. There's other practitioners that they're niche and they enjoy the other side of it, and athletes can go to them. And we have that in-house here at Juggernaut, and so it's totally fine. The reason I don't use a lot of that stuff is because based on what we know right now with the literature, there's not a great way to differentiate why we would choose one modality over the other. And it almost comes down to whatever your personal bias is or whatever course you decided to go to first. If you're Joe and you just happen to go to an instrument assisted soft tissue course first, that's going to be what you say works. If you liked it, Bob chose to go to a dry needling course, and so that's what he says works. And then Joe and Bob are arguing about which is better, but neither one can actually differentiate the two. The mechanism of why of why something works is very important. And if we cannot explain or differentiate why we would use a modality over the other, go back to medication. Why am I going to pick the blue pill over the red pill?
Exactly.
As it stands now, the blue pill and the red pill give similar outcomes, but we don't know why. We don't know the mechanisms. And I think that's maybe not dangerous to the extent of life and death, but I think it's dangerous in regards to healthcare costs and creating dependency, on said treatment. So I stay away from that stuff. And until there's a better explanation and not just this blanket statement of some type of neurophysiological, outcome, I'm giving you a sensory input. It's a neurophysiological realm, which I completely agree with, but that's almost a cop out. It's almost a safe place for people to go. And as I said, there's no way to assess and say, oh, I need to use a tool, a metal tool for this, not a needle. But in this case, I need to use a needle and not the tool. There's really no way to differentiate. And so I stay away as of now. Always reserve the right to change my mind and progress, and hopefully have not hung myself up too much into my bro bias of just get them strong. And if compelling evidence to the contrary presents itself, I will certainly consider it.
Yeah. And one of the things that I guess makes you an exception to the rule in terms of most practitioners, Quinn, is you have quite an extensive lifting background yourself, as well as being a strength and conditioning coach. Unfortunately, not all physical therapists and practitioners do have, the experience that you have in the gym. So how advantageous is it for physical therapists to have that experience? And then why is it important to speak the same language as athletes when you're treating them to get buy-in and, that trust for the rehab protocols and the process to getting them back to their best?
Yeah, I think the last part you hit on is just the creating buy-in, creating, setting expectations. So another colleague has always said, the best thing that I can do the most important thing I can do to get a good outcome is to just help the patient like me. I want the patient to like me as a person. Like I want us to be buddies, and things are much more likely to stick. They're going to be much more likely to adhere to the program. Because you could have the perfect intervention or the perfect program, but if they don't buy in and they don't like you, as a person, then it's not going to work. Or it's going to be much more difficult. And so I think it depends on the population, to your question of how important it is to be a PT who lifts or a practitioner who lifts. I think it depends. If you treat, just 70 years old and up and nobody cares about that, then it probably doesn't matter. If you're treating athletes on a daily basis, especially in my situation where we're treating barbell athletes, and so the training is the sport. It's a very unique concept. That population is very unique because every day they're doing their sport. It actually makes it kind of easy because it's very predictable. Somebody goes out on the football field, I don't know what's going to happen, but you're going to snatch a clean and jerk. All right, I know those positions. That's
controlled environment.
Yeah, totally. Having done that, and so I am. The athletes here at Juggernaut are incredible. I have as much lifting experience as most of them, but just not to the level. But I think it's one of those things. It's like they say, that sometimes the best coaches made the worst athletes, or the vice versa, or something like that. Probably my case. But I have competed in the sport of weightlifting for going on 7 years now. And then before that, it was I've done a few powerlifting meets. I even dabbled in competitive CrossFit for a short time. I'm a sprinter. I got no gas. I got no engine. Then I played football in American football in college. And so I had many years of the barbell lifts. And I think that it has helped from a coaching standpoint, absolutely, because I know the positions. I feel them every day. I still train that way. And so it's very easy for me to kind of fine tune and tweak positioning to change pain perception, because movement can change pain in the short term. If I can alter a position and that decreases your pain, well, great. We'll roll with that until Mother Nature does her thing. And it's very helpful now that I know the positions, and also having played football and competed in these sports, I've also been subjected to many of these similar ailments. And so with my experience personally, and then with knowledge that I've acquired in regards to adaptation and tissue loading and all these things, it makes for a nice combination, because we can make it as predictable as possible, which is what we want. We want to a systematic approach, and we want to be able to create timelines and things like that. So in my situation, it's absolutely vital. And I think that it is still important to a degree for anyone who's going to work with athletes. And it's very important for the public to know too, that physical therapy school does not teach you that. I got like a half a lecture on the functional movement screen, and then like a lecture on integrated rehab, or like higher level. It was not good. It's not their job. They trained us to be generalists. I had as much training in PT school to work in a hospital that I did in an outpatient, sports setting, and much more so with the other one. I used my coaching background before, during, and after, and just self-education with the literature and so if you have a physical therapist or another practitioner who has that background knowledge, they acquire that on their own, and that's a good sign.
Yes.
That's good. And that's why we developed the Clinical Athlete Network for practitioners just like that. Like we're trying to put together. Yeah, trying to put together those types of clinicians for the public to find, because they're not easy.
No,
it's
not.
hard. Yeah. So I don't even remember your original question. I hope that.
No, that was perfect. That was perfect. And I guess the primary reason people come to see a practitioner is because of pain, and pain is such a complex, subjective phenomenon, and defining it is so difficult. Can you shed some light on how pain typically arises for athletes in lifting, and some of the common causes of pain?
Yeah, you mentioned that pain is complex, and I don't pretend to be a pain expert. I think just preface it by going and learning from guys like Lorimer Moseley, who's kind of on the forefront of pain. He's a researcher, and he also can take it and put it into digestible format. And I think that's a great place to learn. So pain is, as you mentioned, a subjective perception. If you're not conscious of pain, then pain does not exist. And I'm going to describe it the way that we understand pain now, and in my understanding of it based on guys much smarter than me. So think of pain as an output. Your brain interprets a sensation or an input as pain, and then I consciously feel pain. It's a danger signal. Pain is what's we've acquired, is a perception we've acquired to stay alive, right? It tells us to stop doing something or to change in some way. Now, nociception, I think, is what a lot of people is the word that I think people equate to pain, and they're not necessarily the same thing. And so nociception is an input. You have nociceptive nerve fibers that send signals to your brain. And so if I touch something hot, or if I bang my leg against a chair or something like that, those signals will be sent to our brain. It's up to our brain then to interpret something as conscious pain, as an output. It may not. I may hit my leg against the table, and it's not really hard enough to cause any dent or to be a danger signal, and so my brain just discards it. I don't even realize it. And we've all experienced that stuff. We look down and all of a sudden our leg is bleeding or something like that. It's like, what the hell happened? I didn't even feel it. And so that's why, nociception and pain are sometimes poorly correlated. And it's very important then to understand that, because that also goes into the structural mindset. And we have this a lot of times, a lot of medicine was built on the structuralist approach, where if I see something on your imaging, or if there's something wrong with your actual physical structure, then you will feel pain. And what we're seeing is that it's not that simple. And there are large percentages, or the high percentages of people walking around with what would be diagnosed on imaging as bulging discs, torn rotator cuffs, torn labrums in their shoulder and their hips, and and the meniscus in the knee, but asymptomatic, no symptoms. And then on the flip side, there are people with pristine MRIs. It looks great. You look like you got 18-year-old knees. It looks perfect. And then they can have debilitating pain perception. And it's multifactorial. It's just so complex. Are they stressed? Or they have the type of personality that dwells on things? Do they have a past experience that was traumatic? And now anything that even comes close to that experience is perceived as pain and danger, and there's fear there. And it also, any practitioner or professional that they've seen in the past, those interactions play a huge part. I know that if somebody walks in my door with low back pain, and they slap an MRI on my table and they say, yeah, my doctor just said that I look at all these things wrong with me, and they just said you better stop lifting or you're gonna need a you're gonna break your back or something like that, or you're gonna need a hip replacement in 5 years if you keep working out. Just take up another hobbies. I know that I've got my work cut out for me because the actual injury is far less important. Now it's going to be a ton of education. It's going to be a ton of it's going to be a ton of trying to mitigate that fear mongering that they were subjected to, and just we call it graded exposure. And so now it's going to be my job to pick activities that they can do without that threat response or without that fear, and then we build on that. But you're right. Most people are coming in the door because they hurt, and it would be easy to say, oh, I wish that everybody would come before so that we could prevent pain. But there's prevention is just such a nebulous term. Like we can't prevent anything. And so we can certainly try to reduce risk, but being strong as a standalone doesn't equal no pain, because then no powerlifter in the world would be ever in pain, and flexibility certainly doesn't equate to no pain. And we know this in the literature that just, having arbitrary range of motion more than somebody else is not a protective mechanism for injury or pain. There's plenty of people in pain who do yoga, for the last 20 years, and they can do the splits 3 different ways and they hurt. So it's a lot of education. It's a lot of reassurance. And of course we need to rule out structural things that would need medical intervention. Obviously there's red flags. If your feet are numb and you just pissed yourself, we should probably get an MRI immediately and go to fix that cauda equina syndrome that you got or something like that. But most things, people need to talking people off a ledge is what we do a lot. Yes. And there's nothing pretty about that, but that's pain science. I mean, using somebody's got reactive tendinopathy, they've had knee tendinopathy for 5 years, but it's really hot, the last month it's just been they haven't been able to squat or anything like that. Well, we find maybe we've got to do isometrics that the research has shown it can be an analgesic. You can just feel that muscle burn, and all of a sudden you don't feel pain anymore, but at least it's some type of loading. So we start there. For a generally structuralist diagnosis like tendinopathy, we still modulate pain strategically. And so it is very complex, and I think that's where the skill comes in as an evidence-informed clinician is really just figuring out the appropriate way to integrate somebody back to their goals. But the pain science is just a lot of education, a lot of meeting people where they are, and then just trying to create context, to the situation.
And that's shed a lot of light into pain science, as I'm sure you're aware, for lifters is something that they don't like to experience. But what is the primary difference between being injured and feeling pain? And then what should an athlete do if they're feeling pain during a movement or after a movement?
Yeah, so I always preface this type of question with it depends on many variables, and I have to speak in generalities here because my answer to one situation may be completely different to another. But in general, pain, I don't know the difference between pain and injury. It's definitely context dependent. Maybe you just have never worked out before and you say something hurts because your muscles burn and you don't like that feeling, or you're sore. Your muscles are sore from the workout. You've never really felt that before, so you say it hurts. So sometimes we have to make that differentiation. Are you, is something actually wrong? Does it hurt, or does the muscles working? And usually people will say, oh, well, the muscles working if they're that type of person. For a more seasoned athlete, maybe there is no difference. If something hurts and you're having to shy away from it, or you're having to alter your movement to get around it, or you're not hitting your volume because something hurts, then we're going to treat it the same as an injury. And the injury maybe we'll define at this point as something's torn, like some type of sprain, a true inflammatory state. Like obviously your body there's damage there that now your body is reacting to, and there's usually pain, conscious perception of threat associated with that. Sometimes there's not. There's no inflammation. There's no tear. Structurally, you're fine, but yet you still perceive this pain. A lot of times that latter scenario is maybe the first start. and we call that, there's some type of sensitization going on. Like let's say with the knee, you're starting to feel some anterior knee pain that you've never felt before, but usually it correlates to something going on in your training. Like if you weren't in this volume phase right now, your knee wouldn't be hurting. So we know it's dose related. And so my answer is usually generally the same. We're going to try to manipulate a variable to alter your pain. We have several variables. We have volume just in general. It depends on what you tell me. Like you say, my workouts are usually 4x8, 5x8, 8x8, but my knee only hurts on sets 6, 7, and 8. I say, okay, well that's a fitness problem. That you're overloading, you're being sensitized once you fatigue, and so then we have to stay within your pain-free volume. We don't have to make any more changes than that, because pain is just an indication that you're overreaching in that moment. Yeah. And so let's just not make this too complicated. Stay within your pain-free volume, and then we'll build more slowly. Maybe you were just packing on the progression a little bit too quickly. If you tell me that it hurts on set 1, like it doesn't matter what I do, my knee is going to hurt. It doesn't matter what. So volume, but also a component of volume, intensity. A lot of people will say, my knee, it could be shoulder, whatever. It doesn't hurt until I get up to 90%. Okay, well, guess what we're going to do? We're going to keep your volume. We're going to back off 5 or 10% and get your volume in your pain-free range, and then progress a little bit more slowly. So instead of this block, we'll spread out the block. You'll do exactly the progression that you were going to do. We'll just spread it out. And then hopefully your fitness will catch up and you'll be fine. Now, what if they tell me that it doesn't matter about the percentage? It doesn't matter about the volume. It's going to hurt regardless. It hurts if I just move my arm. Well, obviously, then now we have to make maybe even a movement modification. Right. So if my knee hurts during front squats but not back squats, or it feels better during safety bar squats, or if I have to cut my depth, if I can't bottom out my squat, but if I cut my depth off, maybe an inch or two above where it hurts, then that's where we train. If we need to manipulate tibial angle to get pain-free range of motion, tempo is a huge one. Yeah. All of the tendinopathy literature right now, or it seems to be this way, is pointing towards what they're terming heavy, slow resistance training, which is not even, we think tendinopathy, eccentrics. If you have a tendon issue, eccentric. Well, now we're seeing that it's either direction, concentric or eccentric. Just move slow and get time under tension. Yeah. And what's slowing the tempo down does, it's beneficial not only for tendon or tissue loading, but also it forces you to use lighter loads. And so it's almost protective. It's almost like care of the other two variables. Yeah. Yeah, exactly. But you're still getting good work in. Yeah. So because I say we can reduce the intensity, but now maybe you don't get a training effect, which kind of sucks, right? But if we reduce the intensity and increase the tempo or decrease the tempo, make it slower, so there's more time with each rep, then now you're bringing another variable up and you're getting more of a training effect. And so, and then, again, after that, it's about manipulating probably the actual exercise, and maybe we have to get away from a 2-legged bilateral squat. Maybe you have to go to a split squat holds. Maybe you can't, maybe knee flexion is just not your jam right now, and we have to just go RDLs and pulls and glute bridges, and then our quad stuff is super basic, like terminal knee extensions, and but it's always loading. I mean, it's not about getting strong. Again, I said it earlier. Strength is not a protective factor. Yes, or else we would never get hurt. What's strong enough? It's not intense, but what does make sense is taking out, not recreating the exact pain, but then reintroducing variations that are similar in nature to the goal activity. And that's really all. I mean, that's rehab. I mean, that's really all it is. And so, if an athlete is, back to your question, if an athlete is feeling pain, then my recommendation is see if you can change it by any one of those variables.
That's some fantastic practical advice. It's something that's not simplified for lifters enough, I don't think, Quinn.
Yeah, I think at some point, a lot of what I said is it seems like it's common sense, like, oh, just don't use as much weight or don't do as much volume. But I think the art of making modifications, but only the modifications that you need, and not going all the way back to square one is important, because what we're seeing now in the literature is also deconditioning is not
Yes.
good. And so what I mean by deconditioning is, oh, I hurt my knee or I hurt my shoulder, and I'm just not going to do anything. I took a month completely off, and maybe in a true acute stage, that's going to give your body time to heal, of course. But what you're also doing is you're losing your fitness. The tissue is losing its fitness. Everything is being deconditioned. And then what do people do? As soon as they're not in pain anymore, they feel like they're fixed, and then they jump right back into the program that they were doing.
Yeah.
But now they're in a deconditioned state, and they get hurt again, and they wonder why. And then that's when people jump to surgery. They said, "Oh, I took a month off,
Yeah.
and I went back, and now it happened again. So shit, I don't know what I'm going to do." And it's just like, no, dude. Like, you skipped a lot in there. There was this whole like rehab thing.
Yeah.
That you didn't do. And so that's what we're seeing now is like, let's protect the injury, respect your pain perception, because if you tell me you feel pain, then you feel pain. I'm not going to argue with your perception, but we are going to see what we can train in the meantime, because Mother Nature should take care of things if we're not being an idiot. Now, if it's more chronic in nature, now we're dealing with some centralized mechanisms there. It's not just structure. If it was structure before, now it's definitely not just structure, as far as like chronic, months on end, years, feeling the same type of pain. Those things are much more slow to progress, but the guidelines are exactly the same. It's the success and the outcomes just take a lot longer, and there's more peaks and valleys.
Awesome. And something that I guess is hard to identify for athletes without, x-rays and other things like this, is whether or not they have a structural abnormality that is simply something they cannot change versus a functional issue. Now, can you explain the difference between a structural issue versus a functional issue, and how do athletes go about identifying whether a movement limitation is structure or function?
There's really no good way to explain that over a podcast. I mean, those types of things definitely require some type of an assessment, but you've got to ask yourself, like, we get a lot in the sport of weightlifting, which is a snatch and clean and jerk. We get a lot of people that will say, my shoulder, or I feel like my shoulders are tight, meaning like I say in a snatch, meaning they feel like they can't get their shoulders all the way over their head to get that bar back, behind their ears where they want it for their overhead squat. And then so I always ask the question, okay, your shoulders feel tight during the full snatch, meaning you catch it in a full squat, but how is the power snatch? How do your shoulders feel during an overhead press? You're just like, oh, well, a power snatch, my shoulders feel fine, but it's the full snatch that all of a sudden they get tight. And so you've got to think about it logically. If you have the shoulder structure for a power snatch, the shoulders are not the issue. It's like people blame the elbows too. They say my elbows don't lock out when I do an overhead press, but if I do a snatch, they lock out great. If I do an overhead press, they bend, and so it must be an elbow problem. If you've got the elbows for a snatch, you've got them for an overhead press. And so you've got to think, try to get the joints in the positions that you deem, and you will have to probably change the actual exercise. But if the joints get into the positions during one variation, you've got the same joints for the more complex variation. What is likely a factor is maybe there's another joint structure that's a limitation, but what's more likely is that there's some type of motor skill acquisition deficiency that you have not addressed. Like, so I mentioned the snatch is a very complex movement pattern, and just because you can't receive the bar where you want it doesn't mean that something's tight. It probably means you haven't practiced the snatch enough. Maybe you need to do more snatch balances. Or like another example is like, well, my overhead squat depth is good, but my snatch depth, my hips get tight. My hips are too tight to snatch. But if they get down there during the overhead squat, then it's not your hips. It's something that's happening during the skillful movement of the snatch where you're disconnecting, you're putting the brakes on. So for the hips, for example, if you have a variation that you have better mobility than another, then the joints go there. So like if you can goblet squat your face off, but then when you go real super heavy back squat, all of a sudden you feel like your hips lock up. Well, you're probably not strong enough, and you're locking yourself down into a different position.
Yeah.
And then again, if a let's say light back squat, 30, 40, 60, 70%, you're hitting all your positions, and then 80, 90 plus, you feel like your hips get tight. You have the same hips for 70% that you do for 80%. There must be some type of positional change because the weight is heavier and you haven't trained yourself to hold the same position, tempo, motor skill. So as a general rule of thumb, try to change the variation to get your joint into that position. If your shoulders feel tight with a barbell strict press, grab a dumbbell or a kettlebell and drive a single arm press and do that on both sides in between your heavier barbell sets. Like actually load the variation and the position that you're trying to get into, but just use a regressed strategy. And that's generally my recommendation. I think in my experience, actual true structural blocks, structural abnormalities that don't let your joint go where you want them to go is so much more rare than people want to assume. It's almost like a cop-out because getting strong in certain positions and working very tediously and meticulously to get a certain range of motion takes a lot of work, and it's boring. And so just saying that your joint is tight and then doing a bunch of passive stretching is just a lot easier to implement. There's not as much effort, but it doesn't do as much. And so if usually when, in my experience, if somebody has a true structural block, they know it. Like it's something that happened to them, or they were born with it, or they had a surgery, or they had a fall or an accident. Like it's obvious.
Yes.
It's not this like, no, I haven't really had any injuries, but I just have like scar tissue built up. They just make up these narratives because it's been 3 months and they still can't hit their positions. When in reality, it's probably just not enough skill acquisition. So as I mentioned, general recommendation, try to find a variation that's regressed slightly, but that allows you to get into the position more comfortably, and then hammer that very frequently and in close proximity to the higher level exercise that you're trying to improve upon. And that's a nice way to go about it.
Yeah, and I think that's something that's often forgotten. I wouldn't say as much in the Olympic lifting community as is the strength community, but lifting weights is a skill and hitting positions is a skill, and very much comes down to your movement quality and how you hold positions at various points within a specific exercise. And something that I'm sure you'll agree with that really limits people's ability to hold position is their breathing patterns.
Yeah, well, I think, if we can equate the relevance of breathing or just stabilizing the trunk, because everybody, we're all breathing enough. If you're listening, or if you will listen to this, you've done well enough this far to stay alive with your breathing. But I think being able to control your torso, it's like again, I'll go back to the example of a goblet squat, a counterbalance squat. For a lot of athletes, it's like magic for them to find their squat depth. They look like, a baby giraffe with a barbell on their back, but you put a kettlebell in their hands and have them, and they just drop it like it's hot. It looks beautiful, right? And so it's like, well, your joints go there. Yeah, it is. It's a nice teaching tool, but it gives you the reason something like that is so useful is that front-loaded position almost cues you to organize your torso automatically. Yeah. And that's why a front squat, barring any limitations to the front rack, a front squat can be that way too, because that front load forces your core to engage. And if we fail a front squat, it's not a leg strength issue. Generally, it's because your torso position gave out. And then you had to push, right? And so I definitely cue manipulating tension with the breath, a forceful exhalation, driving air down into that brace and creating this 360 degrees of expansion as a way to help with that. Ideally, the athlete can reflexively just brace, and control their position. Because go back to like a snatch or clean and jerk, the movement's so fast, you're not thinking about that. Or a rugby player, soccer player, football player, if they're on the field, they've got no time to think about their breathing. Their body just has to react. But in a controlled setting like a gym, it can be nice to practice that stuff with some slower, more regressed positions, and you're practicing maintaining tension and being able to create some force with an exhalation and an inhalation. And, even if you're not wearing a weightlifting belt, pretend that you're pushing against the belt in all directions. Certainly a nice tool to have, a nice skill.
For sure. And I think that's something that most people in the current trend have forgotten, is the importance of stability. We get so caught up on mobility and mobbing joints that we often forget how important stability is. But something else I wanted to pick your brain about, Quinn, was the tightness versus stiffness debate. And obviously this is very much semantics, but how do you differentiate between the two? And do you approach treating tightness differently to treating stiffness?
Not really. And I don't even, I've made a video about this before, but I don't even necessarily make the differentiation. My thing is always, can the joints get into the positions that I want to load them, period. Now, let's say it's the shoulder, and the goal is to press overhead, and I lay them on their back. I want to make sure their joints go there. It would be nice if your shoulder actually went there, if your joint actually rolled in that position and, could show me the potential. And that's kind of how I define mobility, is just the potential of your joint systems to achieve a position. And so if I lay you on your back and your shoulder just flops over your head, both sides, I know your joints go there. There's no restriction. Yeah. Whether or not you can put them there under load, fatigue, against gravity is a different story. But in general, what we had defined just tightness as is a perception. Like people say they feel tight, but the same people that say their shoulders feel tight could be the same people that lay on the table and their shoulders flop to there's no structural length discrepancy there. And maybe that's where where the word stiffness comes in, or just some type of structural length extensibility deficiency. But if it is the case where the joint seems to lack the range of motion to get into the positions that we want to load, we will try to load that new position, try to gain range of motion. We'll do so hopefully in an active state, because the literature has shown that if we can load eccentrically, if we can add resistance to a position at end range, we'll get more response. We'll get a range of motion response, and hopefully we get the benefits of mechanotransduction, where we actually create a little bit of control. So for the shoulders, one example would be like a pullover exercise. So if I'm holding a PVC pipe with a plate rolled on the middle, and I'm on my back, and I just let the weight, sink me down, but I'm still having to control the position. Mm-hmm. That would be an example of an eccentrically loaded mobility drill for somebody who's a little short into range of motion. And then hopefully that would correlate to, we would probably then couple that with some type of intermediate, maybe a single arm press or something like that. But then with the other side of the spectrum, the person who's got the mobility, the joints obviously go there, then I'm probably not spending a whole lot of time with the low level stuff. And I'm probably trying to find the most difficult variation that they can perform, because I know they've got the range. Yeah. And so I don't care what they feel, honestly. If they're telling me they feel tight, like I'm saying, look, your joint moves just fine. It's the same with the hips.
Objective versus subjective, yeah.
Well, it's just like, for a squat, you can lay somebody on the table and they always say they feel their hips are tight during their squat, but I move their hips around and there's no resistance. That happens all the time. And so we've got the problem is the variation of squat that they're trying to acquire the skills must be too complex for them. And so we start somebody like that is a perfect candidate to start counterbalance squatting with some tempo, where I'll force them to pause or to go very, very slow and pause in certain positions to create active control. And then we'll work on being able to let go of the kettlebell and hold that position on their own. But so I guess that's a differentiation I make is do the joints get into the positions? And if they do, but you feel tightness, well, then we got to figure out we got to get you, more stable in that position. We got to get you more acclimated and trained, and you probably won't feel that tightness anymore. If it is truly a structural block, which we determined, through moving joints around or whatever, or no matter what squat variation, your joint wasn't going there, like even a front foot elevated split squat, we've got to load it somehow. Yeah. So the front foot elevated split squat is actually an example of a squat mobility exercise that we do very, very slowly. So you're in that split stance and the front foot is up maybe 4 to 6 inches. And I don't know what that is in centimeters, 8, something like that. And then you go very slow. Yeah. And then you go very, very slow into that range of motion, and your front foot is elevated. So your front hip is in deeper hip flexion. It's a nice drill to acclimate somebody to a deeper hip flexion position, but it's only on one side. And so they can control some variables a little bit better. They can control their trunk a little bit better in that split stance position. It's generally more comfortable than a bilateral squat when we're trying to reacclimate somebody to that deep squat position. So that's an example. It doesn't change whether it's structural or their joints don't actually go there or they actually do. It doesn't change a ton. It maybe just changes our starting point.
Right.
Right. But even then, it's more of just a conversation that it changes. Well, probably very much the prescription will be very similar. It's still always the guideline of, well, let's just find the variation that you're comfortable, training in. Let's see where you can move, what variation it is. But the conversation of, the education of do your joints actually go there or not is probably the differentiation.
Yeah. And something I wanted to discuss with you today, you've done a great video on the myths of foam rollers and using these tools too excessively to help us prepare for training. How important is mobility and activation drills for physical preparation in the big lifts? And do people spend far too much time doing these kind of things as opposed to practicing the skill of the movements that they're going to be then performing in their training, in your opinion?
Are you defining mobility as foam rolling?
Foam rolling,
mobility work as foam rolling?
Yeah. SMR and all of those other techniques.
Yeah. See, I'm waiting for the day, and you're right. I mean, that's the way it's really defined in mainstream. I'm waiting for the day where mobility work is defined as just doing the exercise more with lighter weights, or like with a little slower. Yeah. Like doing my squat mobility work just means that I'm taking the empty bar, or I'm taking 60 kilos and I'm doing some pause squats, and you know what I mean. But in general, a lot of people do spend a little bit too much time. I think it just depends on the context. The foam roller is interesting. What we know now is not a whole lot, but what we think we know is that what the roller doesn't do, and it doesn't seem to be plausible that the foam roller can break up your collagen tissues. Mm-hmm. And you mentioned I made a video on this, and I'm sure it'll be just be the dead horse for anybody. Yeah, but there's been some studies that show that to create actual shear force in collagen fibers of deep fascial structures that we generally roll, thousands of pounds of pressure is needed to do so. And so it would be illogical to think that a foam roller could, for one, provide that amount of force, and number two, do that without breaking the skin. Yeah. Like how in the world could you create 2,000 pounds of force and not break the skin, not just like rip apart your flesh? And then the other question would be like, is that, even if we could do that, would we even want that? Like, why would I want my deep fascial layers to be ripped apart? It just doesn't make any sense. No, it doesn't. And then if you, the other side, if you think about it, or not the other side, same side, if you think about it from a training perspective, if we were that malleable, if we were made of clay like that, the back squat would just, it would annihilate us. Like the bar would just sink into our upper trap. And just, crush us. We would be obliterated with the bar if we were that fragile. So thank goodness that it's not that way. And so what we don't know, but we do know that there's evidence that the foam roller can increase range of motion in the short term. It can decrease pain perception. It can, and pain threshold. So your tolerance to it can do like a pinprick or poke you, and it would be painful. And if you foam roll, then it's not as painful anymore. What's interesting is that lots of stuff can create that short-term change. I mean, just jumping on the exercise bike, doing more of getting actually warm, drinking a cup of coffee right before you train. I mean, seriously, there are so many things that can just give you a short-term pain perception. There's nothing special about the foam roller. If that is your choice, if that is your modality of choice to give you that short-term change, that's fine. I much prefer if I know that a dynamic warm-up, which I do because the literature says that a dynamic warm-up can give you the same range of motion improvements as a foam roller, then I'm going to pick that because I can get my skill acquisition there. Like I can do the empty bar. I can practice just snatches. I can practice my squat tempo and groove. I can practice my bench press groove over and over. Like instead of rolling on the roller for 20 minutes, why don't you just take more warm-up sets of your skill? Why don't you do more med ball throws or something like some more sprint drills to get warm? Just do more of them, and you'll get the same adaptation, but now you've acquired skill. But having said that, people do like the foam roller, and so I acknowledge that. And so I say, if you're going to use it in short, minimum effective dose bouts, short bouts, minimum effective dose. So if 10 seconds gives you that pain, decreased pain perception, then 10 seconds it is, go into a movement. And that I like, instead of having all of your foam rolling front loaded, like 20 minutes in the very beginning, intersperse it in between your workout sets. Because it doesn't decrease your power output. At least literature shows that now. And so that's not necessarily a concern. There's been some talks of like, oh, the foam roller is shifting you into a parasympathetic state. I mean, no. Only if you're laying on the roller and you're just like breathing really heavily and meditating for 5 minutes, then yes, you're probably going to shift into a more parasympathetic state. You're going to calm down and probably not want to train. But if it's 10 seconds of just rolling glute out in between your squats,
vigorous,
like you're okay. I mean, you're just doing it to numb, essentially. Like if I bang my knee against the table and I rub it, it's the same exact mechanism. It's just an input. It's an input to override another input. So like I perceive tightness as like the output of my perception, and then I just use another thing that kind of like is actually uncomfortable, and it overrides the pain stimulus.
Awesome.
I think they call that diffuse noxious inhibitory control. So you use a noxious stimulus to override another noxious stimulus. It's interesting.
It's very interesting. And it's amazing how we've all evolved over the years. I've seen so many people go from spending, countless hours on a foam roller every day to now not even using it because they heard one piece of, literature say that it's, not as effective as what we once thought. And, I often think, as you alluded to, the answer lies in the middle.
Yeah, I mean, and we all make that mistake. We go crazy. It's this whole and we just listen to people blindly. I think it's definitely something because I was the guy who was warming up for like an hour and a half even before he was touching the bar. I was hooking a band up to every joint in my body. I was foam rolling everything. Like this was not that long ago. Like 4 or 5 years ago, I was singing a completely different tune. Maybe like 6 years ago, but it was the opposite. I mean, it was literally the polar opposite. But I learned very quickly because that's generally what science does. Is it like, oh, this isn't working? Like, why? And then you learn the mechanisms, and now it makes perfect sense. You're doing things that are actually going to elicit a response. Otherwise, it's also low level. It's just not going to change anything. That's why if a foam roller was permanent, you wouldn't have to do it all the time. It would have broke up your tissue, and that would be that. But it's this kind of perceptual thing that I don't want to hang my hat on that. I want to hang my hat on things that actually change my physiology and give me fitness. And if something like a foam roller can be interspersed in there as just, something to give me like the 0.25%, which is probably a lot more mental than it is anything else. Okay. Yeah. But I think people spin it. They spin it the opposite way.
The other way.
But it's like you said, somewhere there's something's happening. But that they've shown that. It's just that, as I mentioned, there's a lot of things that do the same thing, and so it's your choice what you choose.
Yeah. Awesome. And my final question for you today, Quinn, is you spoke about how if we stop training completely, we become deconditioned and we lose our fitness. So my question to you is, in the rehab phases, what are some recommendations you have for athletes to make sure that they can uphold their fitness while improving the limitation, whether it's an injury, whether it's just pain or mobility or whatever it may be, to build back their fitness. And then the second part to that question is, do people need to do rehab and prehab all the time?
Well, so I'll address the first one with a disclaimer that, again, it must be a general statement, because if you're currently injured, I have no idea what you should do to rehab. So you should probably go see somebody for that, preferably somebody on the clinical athlete directory. And so there's a little plug there.
Cheeky
but
plug.
I think the answer to that first question is what they should do to increase their, or to maintain their fitness, or what to know what to do. I think we've covered it in some capacity. Is figure out, just because you can't do the main movement that you want to do, or at the intensity and volume that you want to do it, doesn't mean that you can't do a lot of other stuff. So find the next tier down. You can't, if it's not the barbell, the straight barbell, is it the safety bar squat? Is it a kettlebell? Is it a dumbbell? Is it a split squat? Two kettlebell front squat? If it's not, and again, I don't want to play internet doctor here, but if it's not recreating your exact symptoms, or there's observable changes in inflammation, like your joint is swelling, you're not getting those responses after that evening or the next day, it feels like you didn't do it. It feels like you didn't do anything. Like, that's a good sign, but at least you did something. You would have felt that way, and maybe even felt stiff from not doing anything, and you would have got no training stimulus. So pick, whether it's, I don't care if it's, front planks is all you can do. Yeah. Put a freaking, put a 20 kilo, 25 kilo plate on your back and hammer some hard, high threshold front planks. Do something. Yeah. Get some cardio in. At least get that going. A lot of people, at least in my realm, don't do any of that. Jumping on the bike for 10 minutes and like getting your heart rate up is like, whoa, what? I don't even run in my car if it's raining, but if you're hurt and there's nothing else you can do, do something. Yeah. You've got to educate yourself now. Like, always the rebuttal to that question is, well, what is the something? How do I know? Well, that's what you just got to educate yourself on. Ask a coach. That's what that's what they get paid for. Like, what can I do instead? And again, your rule of thumb, and this is a sketchy one, so make sure you get an evaluation. But if it's not recreating your exact symptoms during, after, or the next day, that's a good sign. Yes. And at least you did something. Mm-hmm. And then your second question was, remind me.
Do people always need to do mobility work and prehab and rehab drills for the rest of their training career? Because you see a lot of people do it and then they don't necessarily have any issues.
Right. It's a good question. And the short answer is no, they don't have to do that. Well, let's define terms. Rehab would assume that you are having to build back up. Yeah. You're rehabilitating because there was something that brought you down. Now you have to rehab. But we know if you rehab, if you're progressing, and we're dosing it appropriately, at some point you're back, right? Yes, and then you don't have to rehab it anymore.
And then you see people continually doing their, rotator cuff drills forever, and it's like, well, dude, you should be fixed by now.
A lot of that's, it's like, is it bad? No. Is it taking the time away from things that will increase their fitness? Probably. Everything has a place. It's like the rehab or the TheraBand, rotator cuff exercise is probably great 2 weeks, 4 weeks, 6 weeks post-op. That was all you could do. You had to do that. But like a year after, you're not. It's just a mental, like, it's not doing anything. Go move heavier weights. It's the same. We use that stuff as like warm-ups. You get the muscle to burn. Maybe you're feeling a bit beat up and you're sore. So we'll throw in some of that lower level, like kind of isolation stuff. Just do blood flow, and also the muscle burn is like analgesic. You just feel better. That's the same with like clamshell, glute bridges, all these super low level exercises. But to your point, I think people put too much stock in them as they, if they are going to maintain my fitness or they are going to protect me from injury, and they're usually just not enough stimulus. Mm-hmm. If we use them, it's number one, that's all we can do at the moment because we're still rehabilitating. you're in a stage where you're just so jacked up, we can't do anything else but a glute bridge or a clamshell.
Yeah.
That's fine. That's where we are. The goal is to move away from that stuff as soon as possible. And then we reintroduce it maybe to teach a pattern, like to give you, so I want to work on my deadlift lockout, or like, let's do some really like focused glute bridges between your warm up sets of your rack pull, because we're practicing a motor skill. But but that's different than what like the question that you're asking is like injury prevention. That's probably not the case. Probably not. Yeah. The deadlifts are what are reducing your risk most likely. Being strong and resilient and fit. That's your injury reduction program right there. And then the prehab is an interesting word. I think that's a buzzword that's a bit misused as well. Prehab in the rehab in our field is a specific thing. It's the exercises and the training that you do before a surgery. It's your prehabilitation. Rehab is after the surgery or whatever. But like, let's say somebody tears their ACL and their surgery is not for another couple months. We're going to do as much as we can, and that's our prehab. We're going to squat, lunge in some capacity. We're going to train the glutes and the hamstrings and the quads as much as we can. That's prehab. That's true prehab, and it's the way it's actually intended to be used in that term. But to your point, everybody kind of like corrective exercise, Ys, Ts, Is, clamshells, crossover symmetry, lists of all of these rotator cuff stuff. That's prehab now. And I think the pre has this assumption that it's preventative.
Yes.
And that's just not the case. The fitness, higher fitness qualities, strength, power, speed, stamina, cardiovascular, just capacity. Those qualities are what seem to reduce your relative risk for injury. Mm-hmm. And those low-level exercises are just not eliciting stimulus for that. It's just not. They're great to get moving, and they're great to sometimes teach a position, and it's like a starting point. But yeah, I think it's a similar conversation with foam rolling, where instead of putting in the hard work and the stuff that like is mentally and physically taxing that you actually have to recover from, we try to fill it with a bunch of the easy stuff that's like a little bit hard if you do a ton of it, but not really. And then we hope that does something. Yeah.
Awesome. Well, that was a very informative discussion, Quinn, and I can't thank you enough for joining us today and sharing your knowledge and experience in the world of rehab and physical therapy. Thank you very much for your time, and we'll speak to you next time.
All right. Well, I appreciate it, Jacob. Hopefully we don't have like picket fencers outside of my office ready to hang me up, but it was great. Thanks for asking all the good questions, and I thoroughly enjoyed it. So I appreciate it.
Thank you, Quinn.